she had been lethargic and had a low-grade fever. She wasn't really eating or drinking like normal for about the past 24 hours. And just doing like an across-the-room assessment, she looked distressed. I could see her breathing hard. She looked pale. She was uncomfortable. She's 92% on room air, and her parents let us know last year she was diagnosed with sickle cell anemia, but she's really never been this sick.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today I have a special guest with an expertise in pediatrics. But even though the case we're discussing is about a kiddo, adults have sickle cell disease too. This patient population can be very difficult to manage, but in talking to our guest about this case ahead of time, I feel like she is the perfect person to help me break down and explain not only the pathophysiology and the pharmacological interventions, but also the valuable role that nurses play as patient advocates for patients with sickle cell. So she shares my genuine excitement for caring for patients, and I think you're just going to love her as much as I do. So Morgan, welcome to the podcast.
Hi, thanks for having me. I'm so excited to dive into this today.
Yes. Okay, so before we talk about the case, can you just briefly introduce yourself? When did you become a nurse? What kinds of nursing things have you done since you became a nurse?
So after I graduated from undergrad, I got my BSN from the University of North Carolina, Wilmington, and went to work at Duke University in what we called the pediatric float pool. So I had the privilege of training everywhere pediatrics, from mother baby to the ICU. We had a cardiac unit, the emergency department, and really got to get my hands into all the different areas of pediatrics, which was a phenomenal learning experience. And after a few years of that, I decided to take it on the road and went to travel nursing. I did rotations in PICUs and emergency departments from Seattle Children's to Boston Children's. I worked in the cardiac unit at Rady's Children's Hospital in San Diego. So a bunch of different spots. And somewhere along the way, figured out that I really had a heart for education, that precepting and working with new nurses was an area that was way more impactful to me than I ever thought that it would be. So I started my company, Archer Review, to really try and innovate nursing education and bring fun, joyous education back into nurses' lives.
Yes.
At least for me, nursing school was like hard and scary and just not a good time overall. And the more I got into it, the more I was like, why? Why is it like this? What are we doing? Who's going to want to be a nurse if we're like eating our young and being bullies and just not making this fun? It doesn't have to be so scary. So that's what I've been doing about the past 5 years, running Archer Review. We have a thriving company with nurses who love being nurses and just want to pass that on.
Awesome. I love it. I love when nurses go into education because they actually love education, not because they're just tired of the bedside.
Yeah,
Yes.
Definitely. Well, and the thing is, people are leaving the bedside so fast because we've cultivated a horrible environment, and who the heck wants to be there? So we have people just like doing all sorts of things, leaving the profession entirely. And my overarching goal is to make nursing fun again. I know there's times where it's not fun at all, but we can do a lot better at creating environments that nurses want to stay in. And for me, that starts from day one. You go into nursing school, we have to start right then, not later.
Yeah, I love it. I love it. All right, so let's talk about this case because it really is a good one to set the stage to kind of break down all the interesting and fun stuff to learn about sickle cell.
Yeah.
Okay, so tell us about your patient's initial presentation, like whenever they arrived at the hospital. What were you given a report? What signs and symptoms kind of indicated this is a sickle cell crisis?
Yes. So this case that I chose was back in my emergency department days. We had an 8-year-old African-American female. She came into the ED and really mainly for pain, this severe unrelenting pain. It was in her lower back, her extremities, really just all over. Additionally, her parents let us know she had been lethargic and had a low-grade fever. She wasn't really eating or drinking like normal for about the past 24 hours. And just doing like an across the room assessment, she looked distressed. I could see her breathing hard. She looked pale. She was uncomfortable. So we stuck a pulse ox on her. She's 92% on room air. We're doing all the vitals, and I start to grab her past medical history. And her parents let us know last year she was diagnosed with sickle cell anemia, but she's really never been this sick. This is totally different. They're wondering, hey, is this even related to that?
And unfortunately, this was probably the first of many ER visits for her with her sickle cell crisis. Okay.
Yeah.
So you're finding out she has a sickle cell anemia diagnosis, and now that's paired with pain and just overall fever, not feeling good. What is the pathophysiology of sickle cell crisis? Like, why does it cause such severe pain if it's a blood disorder?
Yeah, it's funny to think about. And really, we have to walk it back a little bit and think about the underlying process of sickle cell anemia and how that leads to a crisis. Because you can live quite comfortably with sickle cell anemia. It's when you get into that crisis event that you end up with the severe pain. This is so characteristic of the disease. So, first and foremost, it's an autosomal recessive disorder characterized by the production of abnormal hemoglobin. So we know we have normal hemoglobin. They're those nice, like little donut-shaped biconcave discs, and they carry our oxygen around. They squeeze through our blood vessels. They do a great job of that. In sickle cell anemia, with this abnormal hemoglobin, they're not the big donuts. They're sickled. They look kind of like a moon almost. They're sharp, they're pokey, and they're not good at carrying oxygen. So when we get into a crisis, more and more of the hemoglobin sickles, goes into that weird shape, and we're not able to get oxygen out to the body. All of our microvascular circulation, like going into our fingers and our toes, our eyes, everywhere lacks oxygen. So no oxygen, that leads to ischemia, inflammation, tissue damage, and all of that triggers severe pain.
So speaking of pain and managing these patients that have the severe pain, what are some of the key medications that we can use for pain management? And how do you balance efficacy and safety? Because we want to give a big enough dose to get them out of pain, but not so much that they're like snowed and can't participate in their care.
And that's especially important when we're talking about kids, right? And an 8-year-old presenting that had never had a crisis before, she had certainly never had like an opioid pain medication. And there's a lot of fear around those. That being said, we do use opioids. Most often, it's either morphine or hydromorphone to treat a sickle cell crisis. We have to get that patient out of pain in order to really address the big picture. So usually we'll do like morphine or Dilaudid IV, and then some NSAIDs like ketorolac that help with the inflammation. We really just have to start low and work our way up until we see effective pain relief, especially in this specific case where it was a child, first time receiving an opioid. We're going to start super low and continually reassess to then get to the point where we're balancing pain and not snowing them.
Gotcha. And as far as like ketorolac goes or other NSAIDs, we love them, I think, for an acute management. I think they're really valuable. But when patients are admitted to the hospital for multiple days, sometimes we have to be kind of cautious with the NSAIDs, especially ketorolac for their kidneys, because
Kidneys.
they're also at risk for some kidney failure whenever they're in crisis. So it's a delicate balance of like watching the lab values, giving the meds the patients need, maybe tapering off a little bit if it feels like their kidneys are not doing well. But again, primary goal initially is to get that pain under control. So in addition to pain management, what are some other interventions that have been shown to be valuable for managing patients in sickle cell crisis?
Yeah. So again, walking it back to the pathophysiology here, our problem is oxygen delivery. The two other things we can do to help optimize getting oxygen to those cells, which will get the client out of pain, is fluids and oxygen. So fluids are going to help thin those sickled cells out. We get some more volume, and that hemoglobin can flow through the blood vessels, get oxygen where it needs to go. And then secondly, pretty obvious, giving them oxygen so that it gets to those cells. We only use it when there is hypoxia. So this patient came in 92% on room air. We did like 2 liters nasal cannula. If they're already having an oxygen saturation above 95 or so, then we're not going to worry so much about oxygen. It really won't make too much of a difference. That being said, fluids. We have got to kind of dilute all of those sickled cells so they can flow and get oxygen where we need it.
Good. I'm glad you brought up those specifics about when oxygen is needed, when it's not. I've seen a trend in recent years where like moving away from giving too much oxygen, because we know that can have some bad effects too, with like your COPDers and your more chronic patients. But this patient population actually does need to be oxygenated. Like we're not okay with a SAT of 89 or 91. Like we would be okay with that for a COPDer.
Right.
We do want to keep it like 95 and above. So not that we have to jack them up on a non-rebreather to 100%,
Right. Yes.
but enough to get them over that hump. And like the 95, 96 window is currently evidence-based. So get them over that hump, shoot for like a 97% would be ideal to me. And then you're golden as far as oxygenation. Good.
Absolutely.
Okay. And then beyond pain management, are there other medications that help with complications of vasoocclusion?
So the big medication to help with complications like long-term management that we're thinking is hydroxyurea. So this is something we're not going to necessarily give right now when we're in the ED and we're in a crisis, but we're going to prescribe it long-term to help reduce the number of crisis events. So for this case, it was the first time the client had come in a crisis. She was not on hydroxyurea. She was discharged up to the floor. And at that point, the hematologist did prescribe hydroxyurea. What this drug does is increase how much fetal hemoglobin is produced. So I don't know about you guys. I don't think I knew there were different types of hemoglobin before I kind of got into this, like hemoglobin was hemoglobin. But we do have hemoglobin F, our fetal hemoglobin, that we make in utero and then still make like a teeny tiny bit of, versus adult hemoglobin is that hemoglobin A. And that hemoglobin A is what sickles in our sickle cell patients, causing all of this pain, causing this crisis. So the hemoglobin F, it doesn't sickle. We don't get that same problem. Hydroxyurea boosts how much of that we make. Therefore, we've got more good round hemoglobin that's not going to sickle, and it will reduce how many crisis events happen.
Gotcha. And then when is it appropriate to give blood transfusions or blood exchange transfusions for this patient population?
Yeah, that's a great question. So that walks it back into kind of our crisis event. This is something that would happen in the emergency department if we're really not seeing improvement with pain management, so like morphine or Dilaudid, fluids and oxygen. At that point, the next level of care is to exchange some of that sickled hemoglobin for some regular hemoglobin. So we do that with an exchange transfusion where we take some blood out and we put a new, like a PRBCs, just infused like a normal blood transfusion. And really what I'm thinking about if we're getting to that point is this patient at risk for a severe complication of sickle cell crisis? We know oxygen's not getting out to the body. That's what's causing pain. But what if we don't have enough oxygen going to a part of the brain? Could that cause an ischemic stroke? Could we end up having a myocardial infarction if we're lacking oxygen delivery to the myocardium of the heart? These are very, very severe complications. And if we're getting to the point where our other interventions are not doing the trick, we've got to think about that.
Yeah. And to your point, not every facility has the option of exchange transfusion. So I know there's lots of patients that have to be like shipped out of the hospital they arrive to so they can get that more, not aggressive, but I would say just more effective treatment. Because it's not something you can just like, the nurse draws a little bit of blood out and then you just get a little bit back. It's a whole process with like pathologist and I don't even know, specialty trained people come and do this procedure at the bedside. This is not something that any of us were trained in nursing school to do.
Right.
So not every facility can do it. So most places just do what I call like the top off, where you like top off with a little extra like healthy packed red blood cells. But if that's not effective enough, then we may have to do a blood exchange transfusion, and that might require transfer to another facility. Okay. So when we're caring for these patients, we have lots of options, right? We have just your basic, like little bit of oxygen, little bit of fluids, little bit of morphine. Okay. And then maybe they're so sick that they're going to need like a blood transfusion, blood exchange transfusion. How do we know when the patient is too sick? Like when should we get worried? When do we like sound the alarm, so to speak, for patients that are high risk for deterioration? Like how can you tell like, oh, this is just pain versus, oh, shoot, this patient should probably be escalated a little bit?
So again, you want to be monitoring for those acute, really scary complications, which you want to think like important organs not getting oxygen. So with the brain, that's signs of stroke. With the kidneys, that's a decreased urine output. All of those things we would monitor for like end organ perfusion. If we see any sign that that's going downhill, that's a big red flag right away. There's plenty that we can monitor on the way, though. So pain levels, vital signs, oxygen saturation, hydration status is huge, especially since fluids are involved. We're wanting to keep a really close eye on urine output. If they're peeing well, then their kidneys are working well. We know those are getting oxygen. But one more thing to really keep in mind with sounding the alarm is their respiratory status, because we're looking at oxygen delivery. If their breathing is labored, if they have chest pain, if they remain hypoxic despite intervention with oxygen, those are times to go ahead and sound the alarm.
Yeah, I agree. I just want to echo what you're saying a little bit and take a minute to stress the importance of nurses knowing the signs and symptoms of these worst case scenarios so they can advocate with confidence. So as far as worst case scenario, like you said, clots can go to the brain. We're looking for signs and symptoms of stroke. Clots can go towards the kidneys. Okay, the kidneys start to shut down. There's decreased urine output. I think that what we see the most common, at least as a rapid response nurse, is acute chest syndrome. So I just want to talk a little bit more about the patho there so you can kind of understand what's happened behind it so you can know whenever like, oh, I'm seeing this in front of me. We had an acute chest syndrome actually 2 weeks ago at our hospital, and the woman did not have chest pain. The symptom was worsened hypoxia, increased oxygen demand. And when we finally got an x-ray, we're like, oh gosh, oh yeah, that would be acute chest syndrome right there. Okay. So as far as the patho goes, in children, it's often infection or asthma that might lead to acute chest syndrome. But in adults, actually, it's much more severe. It's often a fat embolism to the lungs. That's the suspected cause. That's like the more than half of them. It's from that. However, since testing for fat emboli requires bronchoscopy and that's not performed routinely, the true incidence of fat embolism patients is really not even known. That's just kind of an estimate. These fat emboli, they form because of bone marrow necrosis from the vasoocclusion. So we're just thinking, oh, like their extremities are in pain. Yeah. Their extremities are in pain because they're not getting blood flow. And when the bones don't get blood flow, they get necrotic too. So it seems like, oh yeah, just give them some pain medicine or I'll get to the pain medicine eventually. But if you think about it, oh my gosh, if I don't treat their pain, then this patient could be having vasoocclusion that's leading to bone marrow ischemia. And that is what ends up causing the fat embolism. So the fat emboli form because of bone marrow necrosis from the vasoocclusion. The bone marrow releases those fat globules into the systemic circulation, and it ultimately gets lodged in the pulmonary vasculature. The other source of acute chest syndrome from vasoocclusive pain are pulmonary arterial microthrombi. So we often think of PEs as like, oh yeah, they had a DVT and it traveled north of the lungs, but not really in the setting of sickle cell disease. I mean, that's possible, but more likely is that the PE in this setting is caused from a microthrombi that's formed in situ, like inside the pulmonary vasculature itself. So whether the PE is from fat or from microclots that formed in the lungs, either way, it causes this terrible cycle. So vasoocclusion worsens hypoxia. Cell death from hypoxia activates the inflammatory cascade, which leads to acidosis, creating this whole cycle of ongoing vasoocclusion and then worsened hypoxia. These patients I have seen get really sick really fast. So it's so important as nurses that we recognize the signs and symptoms of acute chest and get interventions going very quickly. So I actually cut and pasted the diagnostic criteria. Let's see here. Acute chest is defined by new pulmonary density on chest imaging involving at least one complete lung segment and at least one of the following symptoms. Temperature greater than 38.5, greater than 3% decrease in oxygen saturation from a documented steady state value on room air, tachypnea, intercostal retractions, nasal flaring, or use of accessory muscles, chest pain, cough, wheezing, rales. So if they have a white-looking x-ray plus one of those things, we can say this is acute chest and we need to get on this thing. And I feel like this patient population so often is, I don't want to say ignored, but maybe like under-prioritized with regards to their symptoms just because we all know them. We see them so much in the hospital. You know, pain is kind of a difficult symptom to manage because we can't actually measure it. We can't measure it with like a device, like a blood pressure cuff, right? It's just what the patient says. And so it can be very difficult to recognize when these patients are declining unless we're astute nurses that are knowing what to look for.
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
You bring up such a good point. Going through that patho emphasizes why pain is a priority in this patient population. Me coming from like a test prep background, I think about prioritization and, pain doesn't kill anyone, right? Like pain can be lower on the totem pole. It's not like an ABC priority from your exams. But as you just explained, pain is causing a deficit in circulation. So it's causing a priority issue. And if we don't prioritize the pain, they will decompensate.
I agree. And I wanted to add too, again, I cover the adult environment. Most of our adult patients that finally make it to the ER in sickle cell crisis, they have tried all the other options. They usually have pain medicine to take at home. They've tried that and it didn't work. They don't want to come to my ER. They don't want to wait in my waiting room.
Yeah, they're not
They
trying
don't want
to
to deal
be
with the stigma. Right. If they're here, it's because nothing else is working and they know they need something. So speaking of that, sickle cell patients often face this stigma and like misunderstandings, especially regarding their pain management needs. How do you advocate for them in the clinical setting to ensure that they're receiving appropriate care?
Yeah, so I think about it in two buckets: how we're going to advocate to the interdisciplinary team, and then how we're going to educate and advocate to their family, because families need to understand that this pain is physiologically driven. It's not drug-seeking behavior. They're not making it up. It's not in their head. There's a lot of stigma around that. And especially with sickle cell, you're usually diagnosed in childhood. And this is something you deal with your whole life. So like you already said, they're in the ER sometimes quite frequently. They need some pretty aggressive pain meds. And that does come with stigma. So my backing for education to families is kind of what we've been talking about, explaining the physiology so they understand why at a cellular level it's happening, And that will help them accept a little bit more why our treatments are so necessary. And then in the clinical setting, really collaborating with both the pharmacist and the respiratory therapist. Of course, all parties very important, but those are two particular team members I find myself working with a lot when advocating for these patients, making sure that the pharmacist is very aware of their past medical history and what pain medications have either worked or not worked and what doses. They often require much higher doses of pain medication, especially as they get older and they've been on these medications. So just staying in touch with them to make sure that they know the history will help get the appropriate dose more quickly. And then staying in touch with the respiratory therapist, both to make sure we're titrating that oxygen appropriately and keeping a super close eye on their respiratory status, both for overdoing the pain medication and seeing some complications from that, as well as any signs of acute chest. They're going to be another set of eyes that really helps you monitor for that.
Yeah. I, for one, am a huge advocate for PCAs for this patient population. We're so worried about we don't want to, overdo it. And then they stop breathing. Well, a PCA is a pretty easy fix for that, right? If they're too lethargic, then they can't press the button. So as long as we're giving good family education, not to press the button for them, I feel like that's the best option. I went to a sickle celler a couple months ago, and the patient was just writhing in pain. And the nurse was like, I just gave her 2 milligrams of Dilaudid 2 hours ago. I've never given that much in my career to a patient. I was like, yeah, this patient's been using opiates for the last 30 years. Like, she has quite a tolerance. She takes them at home chronically. It's going to require a lot. She had never seen someone in sickle cell crisis to understand how important it is. This is not just someone who, like you said, they're not drug seeking. Yes, they are wanting drugs because they are having real pain from real ischemia that can cause real complications that you don't want to face, right?
Right.
I have just seen, it is so heartbreaking because most of these patients are so young. And they code blue on you, we don't want that to happen. But I have seen patients just decline in less than 24 hours. They came in on room air and 24 hours later, they're in the ICU on the ventilator. It goes really fast.
It does.
As far as recognizing those patients that might be at risk for a quick decline, especially for the ER, if the SATs are low, we just add more oxygen. No one thinks a thing of it. Just keep adding more oxygen until the numbers are what we want. But if you're requiring that much of an increase in oxygen, that should be a red flag in your mind. This patient is declining fast, right? And then also looking at their platelet count. If their platelet count is low or dropping, that's also a pretty bad red flag for this patient. And so, we don't want to just be like, oh, yeah, that person in 35 keeps wanting the Dilaudid. Oh, there's so much more involved. Pathophysiology-wise, there's so much more involved. This patient needs our attention because it is heartbreaking when a sickle celler cardiac arrest because they're so young. And by the time they're cardiac arresting, so many organ systems have shut down. It's very hard to turn things around for them.
It's so true because there's so many organs not receiving that oxygen that they need. So it's not just that one thing is giving out. It's their whole body. And that's what makes it so complicated. And it's just a multifactorial problem that gets hard to address when you get that far down.
So for a nurse that maybe is having trouble advocating for the patient getting more pain medication or, escalating therapy, do you have any resources, tools, data research literature that you would use to support your advocacy efforts?
Yeah. Oh, I'm a big advocate of falling back on your EBP. Go to those evidence-based guidelines. They're from people way smarter than me who have spent their careers specialized in this, and they're telling us what is best practice. So up-to-date best practice guidelines. For sickle cell, I reference the National Heart, Lung, and Blood Institute. So that's the NHLBI. And they have kind of the nationally recognized best practice guidelines for if A, then B, if C, then D. And you can really, I would print it out and put it at the nurse's station next to my chart so that I could follow along. And if a provider was maybe hesitant to increase that dose and I felt it was necessary, we could look at that together and hopefully make an informed decision.
Good. So going back to caring for these patients, not just their physical needs, but also their psychological needs, because this has got to be very taxing.
Sure, yeah.
They're living with a chronic illness. What are some of the psychosocial challenges that you've observed in these patients, especially knowing them from the pediatric side, whenever they're early diagnosis? How do you address these as their nurse?
Yeah, it's for me as a peds nurse, very important to get on top of that right away because you are dealing with the start of a chronic illness. Lots of kiddos that feel very isolated by that diagnosis. And just, it's hard to know, like, there could be these unpredictable pain episodes coming for me at any time. That is really taxing emotionally. So, really, I try to get them connected to other people who know what it's like. I don't know what it's like. I can do everything possible that I can think of, and I'm not enough to give them the support and education they need for the rest of their life. So, patient advocacy organizations, support groups, peer networks, whatever it is, I really want them to find someone who's about their age, maybe a little bit older, but someone in the same stage of life with them that they can connect with and that can be their go-to support person.
Is there anything that surprised you when caring for these patients who are living with sickle cell disease?
I think a big call out is how much self advocacy they end up having to do to get care that meets their needs. They really have to know, hey, this is my normal dose. This is what usually works for me. I've already tried X, Y, and Z. They really need high degrees of health literacy and to go in sometimes guns a-blazing, really advocating for what they need. And it's amazing to see how they take that up and they get what they need. But it's also disheartening to know that they have to take that burden on a lot of times. And it underscores the critical role that nurses play to really champion those needs and make sure that we're caring for them with empathy, understanding the pathophysiology behind this, and helping take that burden off of them.
Yeah, it's good. Whenever you are providing education for someone with sickle cell disease, what do you encourage them to do in terms of like self-care and recognizing the signs of crisis in themselves? Like, when's it time to come in?
Yeah, a big part of managing sickle cell is preventing a crisis from happening. So, this is outside of our rapid response world when we're getting ready to discharge and say, hey, I don't want to see you here again. I want you coming back into my emergency department. So, there's a few things you can do. The first is staying really well hydrated. That kind of goes back to why we're giving fluids in our rapid response. The more hydrated they are, we kind of dilute out those sickled cells. We also want them to identify their triggers for causing a crisis. So, anytime our body is needing more oxygen, we have that higher oxygen demand, it triggers the sickling of that hemoglobin A. So things like that can be extreme temperatures, going up to a really high altitude if you're up in the mountains or on an airplane, stress, a fever if you get sick, basically anything that causes your body to need more oxygen. So we really want to talk to them when we're getting ready to discharge about what those triggers are, avoiding them, to the best you can. You can't always avoid getting sick or stressed, but you can be aware of when that's happening, what you need to watch out for. So getting a fever, feeling short of breath, feeling lethargic, not really wanting to eat or drink very well. Those are all signs that we're moving towards the spectrum of that crisis, and we need to go ahead and address that. The sooner we address it, the lower the chance we end up with any of those scary complications like acute chest.
Gotcha. That's good. All right. So you talked about making sure they know what the triggers are so they can hopefully avoid them and, possibly just respond to them appropriately, like amp up the fluid intake whenever they're going to the mountains or, if they're going to final season, drink more water.
Right, drink water.
So if you were training, say, like a new grad who's about to get an admission that's a sickle cell crisis patient, what are like the big takeaways from our talk that you want to know before this patient arrives? Like, what are like the top, 5 or 6 things they need to keep at top of mind when they're caring for this patient?
Perfect. Okay, let's do top 5. So number 1, opioids. Sickle cell pain is a priority and opioids are evidence-based first line. Number 2, hydrate them. Get them those fluids so that we get good blood flowing. Number 3, give them oxygen if hypoxia is present. So 1, 2, and 3, those are all about getting more blood and therefore oxygen out to the cells. Fourth, watch out for their complications. Everything we talked about, acute chest, if they are not responding to treatment, if hypoxia is worsening, then we need to raise the red flag. And fifth, lastly, advocate and educate. Get them the dose of pain medication they need. Know that pain's a priority. Educate them about the physiology of this so they understand their own disease process as well as their family and how they can recognize early signs and manage that accordingly.
Yes, Morgan, you summed it up perfectly. Yes. Okay. Well, I think that's a good spot to end. That's all the things I wanted my listeners to know. This is excellent. So before I let you go, people are going to want to find you now, Morgan, and get some more education from Morgan. So where can they go to find you?
Yeah, I would love it. Archerreview.com is our website. We have education from those of you looking to get into nursing school. If you're in the thick of it, if you're graduating, trying to pass your boards, or even go back to school, we've got something for you. You can also follow us on all of our socials. If you Instagram or TikTok or whatever your guilty pleasure is, follow us at Archer Nursing. We've got lots of fun little stuff and we'd love to see you there.
Awesome. And I will put all those things in the show notes to make it easy for you guys. All right, Morgan, this has been great. Thank you so much for sharing the story, for sharing your expertise and your time today. I have loved this conversation.
Me too. Thanks for having me. And I hope we get to talk again soon.
Yes. Thanks, Morgan. Have a good one.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.